and this is a featured research session on the new clinical candidates and learnings from anti-amyloid therapeutic trials. We have a nice range of talks for us today. And my co-chair?
G'day, my name is Scott Ayton. I am from the Flora Institute in Melbourne, and it's my pleasure to introduce the first speaker for today, Mia Kivipelto, and she's going to be talking about the role of nutrition and metabolic regulation in multi-domain trials for dementia risk reduction, findings from FINGER and FINGER-2 studies. Thanks, Mia.
Thank you so much for the introduction, and good morning, everyone. It's my great pleasure to be here today and give some new findings and updates from FINGER and FINGER 2.0 studies. Here are first my disclosures and the grant support for the trials I'm presenting. Starting point for our studies is the multimodal approach, targeting several risk factors and mechanisms simultaneously to get the optimal preventive effect. At the same time, we have learned that one size does not fit all. So we are now moving from the multimodal interventions to precision prevention, tailoring the interventions, taking into account various risk profiles. It's really positive to have now the positive findings from the anti-amyloid treatments. At the same time, of course, we need to keep in mind that it is only a part of the patient population who are eligible for these treatments. At the memory clinic Karolinska, where I'm working, it is actually up to only 27–28% of our patients with MCI and dementia who would be kind of candidates of these kind of treatments. So clearly, we also need to have other kind of interventions and novel candidates for the treatments. And this is what we are doing in the FINGER trials. The FINGER study first, and now we have the FINGER 2.0, where we are also targeting patients with early Alzheimer's disease, combining with the different kind of nutritional-based interventions. And then we have the first combination therapies with non-pharmacological and pharmacological interventions, the MET-FINGER trial. FINGER trial was the first large long-term randomized controlled trial to show that it is possible to prevent cognitive decline among at-risk elderly persons from general population with the multi-domain FINGER model with nutrition, exercise, cognitive training, social activities, and taking care of all vascular and metabolic risk factors for 2 years compared to regular health advice. We have been conducting extended follow-ups, and we are now ready with the 11-year follow-up. And beyond the cognitive benefits, we have been also seeing many other positive effects. There were 20% lower risk for cardiovascular events, 30% lower risk for functional decline. Quite interestingly, 60% lower risk for chronic diseases, especially multimorbidity, better health-related quality of life, and also health economical benefits. So I think we can say that we have evidence that the multi-domain intervention is effective and feasible. But the next question is, what is the dose? What is the intensity needed? We have been studying the dose response and the adherence in the FINGER trial, and adherence is of course important in lifestyle interventions, exactly in the same way it's important in pharmacological interventions, but maybe a bit more difficult to measure, especially when we have multi-domain lifestyle interventions. But what we could see was that persons attending at least 50% of all these 5 fingers, then we could see the benefit for the brain health. So you don't need to do everything, but clearly supporting long-term kind of commitment for these 5 fingers is important in the future interventions and in the implementation. We have now started to analyze the 11-year data for the adherence. This is the multi-domain healthy lifestyle. And it was very interesting to see that the intervention group still had healthier lifestyle after 7 years. For me, this was actually much better what I dared to hope, given that the intervention was there only for 2 years. After 11 years, we did not see any differences, as you can see here. However, we are now studying some subgroups, and it seemed that older persons, those who were older than 70, then the differences are still there even after 11 years. We have also started to look at the different domains, and this is the diet, and you see here the fish and vegetable consumption. And here the multi-domain group, finger group, is having still healthier lifestyle, healthier diet after 5 years. We have not measured the effect of COVID pandemic, and we have not yet data here for the 11-year follow-up, but at least after 7 years, the healthier diet is there. For physical activity, it seems that the difference was there up to 5 years, and after the pandemic, both intervention and control group increased the physical activity. There seems to also be differences between the different intervention domains when it comes to the long-term adherence. We have also possibility in the finger data to link that to the registers, and that's something we have done, and this is data up to 8 years. And it's interesting to see that there were clear reduction on healthcare use and also costs in the finger intervention group. There were fewer days in hospital, around 6.2 fewer days, less ambulatory care, and total savings in the healthcare service use was more than 500 euros less per patient per year. And I think this gives a further indication for and supporting the health economic benefits and cost savings. So it's not only individual level, but also on societal level. And here you can see the flow chart, all the follow-ups we have been having for fingers so far, up to 11 years. It was nice that almost 70% of the finger participants still came back after 11 years. 20% had died, but as said, we have also the possibility of linking this data to these health registers. And we are now conducting a lot of sub-studies. We have MRI, amyloid and synaptic density, of course, AD blood-based biomarkers during all these follow-ups up to 11 years, and omics and so on. And I think this is important to give more understanding what are the mechanisms under the multi-domain intervention, what are the mechanisms behind the cognitive gains. And we are updating now the finger-to-finger 2.0, and we want to combine the model with multinutrients and putative disease-modifying drugs. And here the first model and results are already ready. We had the MIND-AD study in 4 countries targeting patients who had prodromal AD with vascular and lifestyle factors. And here we had one arm where we combined lifestyle and medical food. We had the Fortasyn Connect, which is an omega-3 base with a lot of different nutrients which are important for the brain health. And especially if you have early AD, our idea was that you may need some extra support. It's not enough with only dietary support. And interestingly, as you can see here, the retention rate was very high, over 90%, as well as adherence for all these different domains. It was between 78 to 87%. And also, there seemed to be benefits, clinical benefits, so that this group, having the combination, showed decrease in vascular risk burden, increase in healthy diet pattern, and even cognitive benefits measured with CDR sum of boxes. And this gives further support and importance of the nutrition-based interventions, and also it's never too late. You can always do something even with this type of interventions. And finally, this data gave to us the rationale to move on and combine finger with the possible disease-modifying drug. Here in the MET finger, we combined finger with metformin, diabetes medication, because there are many links between diabetes and Alzheimer's disease. And there are now very interesting studies indicating that persons who have been using metformin seems to have a lower risk of Alzheimer's disease. But this combination has been never tested if you combine lifestyle and metformin. We have here 600 participants from 3 countries, quite similar study design what we had in finger at-risk persons, but we have 2-step randomization. So persons are first randomized to get the multi-domain lifestyle intervention or control group, and within the multi-domain intervention, there is a second step of randomization, so that persons are getting metformin in different doses. Not all, but only those who have the eligibility criteria, for example, obesity, metabolic syndrome, and so on. And we also use ApoE for enrichment. So this is, for me, the precision medicine approach. We are trying to give the treatment for those who have the increased risk, right treatment at the right time. We have now recruited 70 persons, and as you see, there are 42 who have ApoE4, so the ApoE enrichment strategy seems to work. And for me, this is the model for the next generation of combination studies where we can use also different kind of treatments. So concluding then, I think we have evidence that the long-term multi-domain lifestyle changes are both feasible and effective. Finger 2.0, lifestyle and medical food, is feasible, and there are some beneficial effects even in prodromal AD. Again, it's never too late, and the nutrition-based interventions are important. And finally, MedFinger model, which I see is the model for new next generation of combination studies, and we'll learn a lot about this, about the added or synergistic effect. Finally, I want to thank all my colleagues, and I want to thank you for listening. Thank you so much.
Thank you, Mia. Just to remind everyone, we're going to take all the questions at the end, and if you want to submit your questions online through the app, you can. Please state who they are for, so it makes my job a bit easier. So I'd like to introduce my co-chair, Scott Ayton, who's going to be talking about brain volume changes caused by anti-amyloid beta drugs and the association with ARIA. Thank you, Scott.
Thanks everyone for coming to this early morning session on the last day. I really appreciate it. And I want to thank the organisers for this really wonderful symposium, a really wonderful conference, and for giving me the opportunity to speak. Feel free to take photos. These data have recently been published, and this is my disclosures for today. We're now in the therapeutic era for Alzheimer's disease. A key unresolved question is whether a relatively modest benefit observed in clinical trials will lead to lasting change for patients as they're treated in the clinic in the long term. Or do patients receive an initial boost to cognition that is not sustained? I think answering this question will really determine the value of these drugs in the clinic. And given that the cognitive effects are a little bit uncertain, we could look at secondary outcomes to determine, to get further information about their likely benefit. One thing to look at is brain volume, as brain volume is the proximate change to cognitive change in Alzheimer's disease, and is an objective biomarker that we could look at. Typically in Alzheimer's disease, we look at whole brain volume loss, hippocampal volume loss, and ventricular enlargement as the brain atrophies. Of course, there are many regions that are affected in Alzheimer's disease, but these are most typical. And we reason that disease-modifying drugs should indeed prevent neurodegeneration if they are indeed disease-modifying. So to investigate this question, we did a meta-analysis of anti-amyloid drugs that had a positive effect on at least one biomarker of amyloid, and also measured brain volume in at least one brain region. And in our survey of these trials, we identified 31 clinical trials of 14 drugs. We classified the drugs into secretase inhibitors, monoclonal antibodies, and other. Our first observation is that anti-amyloid drugs that induced ARIA had accelerated ventricular volume loss compared to patients on placebo. And you can see here these a rightward shift on this forest plot indicates accelerated change, and these dots represent, the size of the dot represents the number of participants in the trial, and each of these dots represents multiple trials. For example, the top one, aducanumab, includes 2 trials and almost 1,300 participants. The other drug classes did not accelerate ventricular enlargement. You can see down the bottom in the pooled analysis, it's really the ARIA-associated drugs that are causing accelerated volumetric changes. I need not introduce ARIA to this audience. Amyloid-related imaging abnormalities with edema or hemorrhage can be either asymptomatic or in less common symptomatic and severe. The long-term consequences of ARIA have not yet been investigated. And I think that that is important because we found a very striking correlation between the frequency of ARIA and the degree of ventricular volume change. This is a graph of clinical trials. Each one of these dots represents a clinical trial with the size of the dot proportional to the size of the trial. And you can see that trials that reported increased ARIA frequency were associated with accelerated ventricular enlargement change. Next, we looked at whole brain. And in this case, a leftward shift is associated with the acceleration of whole brain volume loss. And you can see the front-running drugs, donanemab and lecanemab, were associated with accelerated whole brain volume loss, but not aducanumab and bapineuzumab, the other ARIA-associated monoclonal antibodies. We also saw this same degree of change in secretase inhibitors. The results for the hippocampus were more mixed. We did not see that any of the amyloid drugs were associated with a significant acceleration to the hippocampus. The secretase inhibitors, however, certain secretase inhibitors were associated with accelerated hippocampal volume change. We did not see such a striking correlation between hippocampal and whole brain volume change when related to the frequency of ARIA compared to what we saw with lateral ventricles. Is this change significant? Well, this is, I think, a question we really need to investigate further. These changes have been characterized as being significant but small. But our meta-analysis shows that the rate of increase is around 40%. And so to contextualize these findings, we did some modeling of previously published data, and we tried to approximate what the impact of taking an anti-amyloid therapy would be in an MCI patient over time. And we predicted that an MCI patient taking an anti-amyloid therapy that induced ARIA would have a brain volume approximating somebody with Alzheimer's disease 8 months earlier than if they were untreated. Similar results were observed with whole brain and hippocampus, which depended on drug and drug class. So to conclude these data, we think that these data warrant concern, but we don't know. We do not know whether these data volume loss are damaging or they're benign, and it's my sincere hope that they are benign. But the call of this paper and my talk here is that we need to investigate this. And the point I'd like to make is that trial sponsors held the necessary data to understand this risk more, and they need to be investigated. What I've shown today is really just the tip of the iceberg, and we really need to investigate this more. I think it should give us pause that as a community, that as these drugs are being released into the community today, that we can offer no real good explanation into these findings. But there are, with the available data that's currently available data, we can ask some key questions which would help contextualize the findings. So what are some of the unresolved questions? I think chief among these is whether ARIA causes accelerated volume changes. As I showed you, there's a striking correlation between the frequency of ARIA and the degree of volume change. But also, in the one study that we're able to, study that stratified the volume changes according to ARIA, a bapineuzumab study, these authors showed that people on bapineuzumab that developed ARIA had accelerated volume changes compared to bapineuzumab-treated patients that didn't develop ARIA. So I think that's a high degree of probability that ARIA is driving volume changes, and these really need to be investigated in the drugs that are entering the clinic now. This is a very simple analysis to do. Another thing we could look at is perhaps the negative impact on volume changes are not measured in existing timescales of the current clinical trials. This is where longitudinal follow-up becomes very important. I mentioned before that there's an early benefit to cognition, but the volume changes occur much later, beyond a year, that we start to see them really emerge. So it could be that the volume changes are having an effect later on. And this may impact on how long we treat patients for. Also, what areas are affected? We've really restricted our analysis, or the data that's being presented is really just whole brain volume, ventricular enlargement, and hippocampal volume. But there are a range of brain structures that could be affected. And in the one study that did investigate this more thoroughly, the donanemab phase 2 study, these data were published on clinicaltrials.gov. They showed that donanemab caused accelerated changes to a range of brain structures. And so I think we should look at this in an unbiased way to determine what are the brain structures that are affected, and this may impact on what clinical symptoms to expect. What's the cause of the brain volume loss? It's been characterized for many years as loss of plaque volume is causing the loss of brain volume. But we've argued that this is really unrealistic. The amount of plaque really cannot account for the degree of volume change. We've done some mathematics around this, but there are a range of other arguments. The plaque loss is quantitatively, spatially, and temporally disassociated with the volume loss. One example here is the temporal disconnect. There's a loss of plaque volume in a very early stage, but the volumetric changes happen much later. So we cannot explain the loss of brain volume by loss of plaque volume. It's also been said that inflammation causes increased brain volume because with infiltration of immune cells. And then so the reduction of inflammation with anti-amyloid therapies is contributing to apparent volumetric loss. I think this is a really interesting idea, but we need the evidence to support this. And the currently available evidence is actually arguing the opposite direction. ARIA is a MRI detectable inflammation, and if this were the case, if that hypothesis were the case, we would see that ARIA would be associated with increased brain volume, but it's dramatically in the opposite direction. So I think that this concept of inflammation changing brain volume really needs to be supported by evidence. The current available evidence is not supportive. To deal with this uncertainty and potential risk of accelerated brain volume, we've put 6 recommendations, and I encourage you to look at that in the paper, but it's really summed up by this quote from the husband of a participant in the ENGAGE aducanumab clinical trial. And he said to me, "I know from personal experience how much a successful disease-modifying therapy is needed, but this has to be properly considered and the pros and cons identified systematically. Unless pharma publishes properly, there won't be the solid progress we need." And whether you agree with me that these findings are concerning or not, I hope you would agree with me that we need to look. And so my call is that we should be looking at these safety data more extensively to try and determine the potential impact of these drugs. With that, I'd like to thank my collaborators, Francesca Alves and Pav Kalinowski. Thanks very much.
Thanks, Scott. So I'd like to invite Dr. Brian Willis, and his talk is Exposure Response Modeling to describe the change in brain amyloid following lecanemab administration in patients with early Alzheimer's disease. Thank you, Brian.
Thank you very much. Good morning. I'd like to provide my disclosures and the names of my co-authors. So, as you're probably aware, lecanemab is an anti-amyloid antibody that has high affinity for the soluble protofibrils. And in our phase 2 and phase 3 studies, we showed that lecanemab was associated with the robust amyloid lowering that was both time and dose dependent. We wish to better understand the impact of lecanemab concentration and patient-specific factors on amyloid lowering, and so we conducted some PK/PD modeling in order to better understand that. And in this presentation, I'm going to share with you some of the insights that we gained from that modeling. So to develop the PK/PD models, first we pooled all the data from our phase 2 and our phase 3 studies. The phase 3 study 301 was also referred to as Clarity. In the first step, we developed a the PK model and found that lecanemab followed a fairly typical 2-compartment PK model. After that, we developed an indirect response model to describe the change in amyloid plaque. And the formation of amyloid plaque was described as a zero-order input and a first-order removal process, which you can see there on the right-hand side, the degradation. And as we were attempting to develop models, the most appropriate model to describe the effect of lecanemab was that lecanemab increased this rate of amyloid elimination proportional to the amount of concentration that was in the serum. So in this slide, we talk about how well the model actually worked and what we found from the model. And what you see on the left-hand side in this figure is we have taken the observed results from our phase 2 and phase 3 studies, and we have plotted out the median and the 5th and 95th percentiles of the observed data here in red. And then what we did was we took the model and we simulated the results of these trials 500 times using the dosing information, the observed time of PET observation, PET scans, and the patient-specific factors that were relevant. And then we looked at the medians and 5th and 95th percentile of the simulated data, and we overlaid that with the observed data. And what you see is that the red lines, which represent the observed data, and the black lines, which represent the simulated data, closely overlap one another, suggesting that the model we developed is able to closely replicate both the central tendency of the data as well as the spread of the data. There were two significant covariate effects that we found as part of the modeling exercise. The first was that ApoE4 carriers tended to have a higher baseline A-beta PET than the non-carriers, and you can see this in the table at the top. In the observed data, there was about a 20 centiloid difference between non-carriers and carriers, and you see that the model reflected that in its output. We also found that there was an increase in amyloid removal in older patients, and I'll talk about the significance of that in a future slide. The other thing that's important here is that if you look at the half-life of amyloid reaccumulation, which is a way of thinking about how quickly amyloid is going to reaccumulate after stopping lecanemab treatment, we found that that half-life was about 14 years, which is consistent with other models that have been published out there that are also looking at anti-amyloid antibodies. And so what we want to do with this model was look at two sets of simulations to really understand lecanemab dosing. And so on the left-hand side, we look at every 2-week dosing versus every 4-week dosing. So at the end of the phase 2 trial, we made the decision to push forward with every 2-week dosing. Wanted to verify that that was in fact the most appropriate dosing regimen to use. And you see that the blue here, which is the every 2-week dosing, did achieve amyloid clearance much faster than the every 4-week dosing, thus justifying the every 2-week dosing regimen that we used in the phase 3 study. On the right-hand side, we wanted to understand what happens after we stop lecanemab treatment, or after 18 months of lecanemab treatment, rather. And so in the gray lines here, we actually stop treatment. And what you see is a slow increase in centiloid levels, sort of this return to baseline. And what we see here is about 2 or 3 centiloid per year, which is very consistent with the presentation that we saw here earlier this week. But we also wanted to understand what would happen if you continued dosing with lecanemab. And you see here in the blue line, you continue dosing the every 2 weeks. And what we notice is if you compare that with the every 4-week dosing, both of these lead to continued suppression of amyloid PET, suggesting that there's continued benefit to maintaining lecanemab treatment. The next set of simulations we wanted to do was to understand the effects of those covariates I mentioned, the ApoE4 status as well as age. And what you see in these is that the older patients did indeed remove more amyloid than the younger patients, and the ApoE4 positive patients removed more amyloid than the ApoE4 negative. So all of these are in reference to what we call the reference patient, who is 73 years of age and ApoE4 negative. The ages here, the 83, the 57, and the 73, these two are the 5th and 95th percentiles of the data that we actually had in our clinical, our model database. And the 73 was the median age that we had. So that's where those numbers came from. One of the thoughts when we saw these results were that potentially there was some difference in baseline amyloid level based on age. So older patients might have more amyloid. But when we actually look at the baseline amyloid PET scores versus age, we see that really there was no trend there. So at least in the study population that we pulled from, the amyloid levels didn't really change across age at baseline. And so we wanted to explore this a little bit more. And so in this slide, you can see the effect of ApoE4 carrier status, and you can see that difference in baseline score reflected here. But you see at the end of the 18 months of treatment, there really is very little difference between the two, suggesting that the reason that you lose more amyloid with the ApoE4 carriers isn't necessarily due to something special about lecanemab. It's just that in our study, the ApoE4 carriers had more amyloid to remove, and so they removed it. But at the end of the study, everyone was about the same. On the other hand, when you look at the age effect, you do see that the older patients are losing amyloid much, much faster than the younger patients, although both groups are still losing amyloid at a fairly good clip. One important thing to notice about this, though, is that we're not the first anti-amyloid treatment to describe this. So aducanumab has also seen the same effect in their study. And that leads to the hypothesis that this could be something consistent across all the anti-amyloid antibodies. And so especially when you're trying to compare results across different clinical trials, you probably want to look at the median ages in the study population in order to make sure that when you're doing your study-to-study comparisons, you're doing an apples-to-apples comparison. Finally, this set of simulations are, you may have seen if you came to my presentation on Monday. These are how we were using this model to support subcutaneous dosing for lecanemab. So in the panel on the left, we wanted to understand whether we could move from the body weight normalized dosing we were currently using, 10 mg per kg, into a fixed dose, which would be appropriate for a number of the subcutaneous dosing formats, such as prefilled syringe or auto-injectors. And so in the red, you've got 10 mg per kg every 2 weeks versus a flat dose of 720. And so for the 70 kilogram group, you see that really there was no difference between the two, which makes sense because it's essentially the same dose. But even moving to the extremes of 50 kilograms or 100 kilograms, you see that the overall impact of switching to the flat dose is fairly minimal. And so that it seems to be appropriate to use a flat dose. Our theory for how to set doses for subcutaneous administration was that we needed to match the steady state concentrations with our subcutaneous dosing form that we had achieved with IV. And so based off of what we learned about subcutaneous administration in our PK model, we understood that a 720 milligram IV dose given every 2 weeks would give you the same exposure as 720 milligrams sub-Q every week. We put this into our model to make sure that our assumptions were correct here and to verify that we weren't missing anything. And as you can see, there are actually 2 lines there, and they are perfectly superimposed, suggesting that that is the right approach to take and justifying the dose we want to take forward for subcutaneous administration. So in conclusion, we've developed a PK/PD model that really describes the change in amyloid after lecanemab administration. And we've identified 2 covariate effects that can help explain some of the variation we saw in the clinical trials. We've seen that older subjects do remove amyloid faster than younger subjects, but this might be something that's seen across the anti-amyloid antibodies. We also seen that although we saw a difference in baseline concentrations with ApoE4 carriers and non-carriers, that really didn't have any impact on the end result of the study. And finally, this model gave us additional insights into dosing and subcutaneous administration, as well as the potential for reduced dosing frequency after amyloid clearance. Thank you very much.
Thank you, Brian. It's my pleasure to announce the next speaker, Richard Kennedy, and he's going to be talking about the effect of concomitant aducanumab on AD clinical trial outcomes. Thank you, Richard.
Yes, thank you very much for that introduction. Just by way of introduction for myself, any photography is welcome in this presentation, and I do not have any disclosures related to this other than my NIH grant funding. So, a little bit about anti-amyloid therapy and its potential effect on clinical trials. As we've heard quite a bit over the last few days, anti-amyloid antibodies are an active area of development, with aducanumab being approved a little over a year ago, lecanemab just receiving full approval earlier in this month, and donanemab looking very promising and expected to gain approval as well. Some of the initial surveys of older adults indicate that at least a quarter of individuals would be willing to take one of these therapies if they have Alzheimer's disease. This is probably likely to go up as we gain more experience and these become more familiar agents. And a side effect of this is that we're going to see more and more of these individuals taking a concomitant anti-amyloid antibody enrolling in clinical trials for newer therapeutic agents or for behavioral treatments. However, as we've also heard a lot over the last few days, these agents are associated with a fair number of side effects that we have to consider. About 9% of individuals taking aducanumab discontinue the therapy due to adverse effects. Predominantly, this is due to ARIA. We should note that symptomatic or moderate to severe ARIA does warrant at least a temporary discontinuation of the anti-amyloid antibody. And there are also other effects besides ARIA that may be severe enough to warrant discontinuation. It's important to note that this would affect trials of other agents because these do require people to remain on stable doses of their concomitant therapies during the trial. So our purpose was really to investigate how much this might be a problem. We wanted to look at the effect of anti-amyloid antibodies on clinical trial outcomes of new experimental therapeutic agents. And we did this through a set of simulations across a range of clinical trial scenarios. Our participants were drawn from a metadatabase that we've previously described, consisting of past participants in the Alzheimer's Disease Cooperative Study, as well as ADNI. And the primary outcome for our analysis was the ADAS-Cog, which was administered at 6-month intervals over a 2-year duration. And we included 8 studies that had the ADAS-Cog as a primary outcome and a duration of at least 6 months. Our primary predictor here was aducanumab eligibility. I've got a full list of the requirements here, but these are modified from the ENGAGE and EMERGE trials and are consistent with the appropriate use recommendations that have been recently published for aducanumab. We did define people who were enrolled in who we used in our simulations as provisionally eligible because we could not determine all of the eligibility criteria retrospectively in our metadatabase, but we did make approximations for these. For our simulations, we used a previously published methodology where we resampled from our metadatabase to create trials that were not exactly the same as the original trials, but fairly similar across a wide range of sample sizes and trial durations. We used an effect size that ranged from none to a moderate effect size for both the anti-amyloid therapy and for the new experimental therapeutic agent that we would be investigating. And we varied the range of people taking anti-amyloid therapy anywhere from 20 to 80%, with a fixed dropout for the experimental treatment at 10% and dropout rates for the anti-amyloid therapy ranging from 0 to 20%. We used a mixed effects model and defined a significant difference as a difference in slope over time using that mixed effects model. So, first off, the comparison of our individuals who were and were not eligible for aducanumab therapy. As you can see from this, those who were eligible on average tended to be younger. They also had a higher level of education, and most importantly for clinical trial results, they had a better cognitive function at baseline and tended to progress less slowly over time throughout the trials. And this is some of our results. In this case, for a 12-month trial simulation across a range of effect sizes for our hypothetical treatment that we're investigating. And what you can see is that over a range of eligibility for aducanumab, for a given treatment effect size, as the eligibility for aducanumab increases, and by the same token, the amount of dropout in the aducanumab group increases, we see a progressive loss of power, in this case ranging from about 10 to 15%, depending on the particular trial scenario. This is a simulation for a 24-month trial, which shows an even more dramatic effect in this case as we increase the eligibility percentage for aducanumab and the dropout from aducanumab as well. In this case, it went anywhere from 20% on up to 70%, depending on the clinical trial scenario that we were looking at. So we really do seem to be entering a new era of clinical trials for Alzheimer's disease, where we really not only have to take into account the new therapy that we're investigating, but also the concomitant medications, specifically anti-amyloid antibodies, that these individuals are taking, which we really have not had to do before. And differential dropout for these therapies is likely to occur in many trials because of the high rates of side effects due to anti-amyloid therapies, coupled with unmasking of concomitant medications during a trial itself. It's also important to note, even though I only showed a small sampling of our trial results, this can occur under a variety of scenarios, including if the new therapeutic agent does have a positive effect, we can still get a loss of power. It can also occur if there's no differential dropout for the novel therapeutic agent that we're investigating, and can occur even if aducanumab itself has no or a minimal effect on cognition overall. This occurs because the individuals who are eligible for aducanumab do differ significantly in terms of their demographics and cognitive progression than those who are ineligible. And it's important to note these are simulation studies. We really do need to get much better real-world information of the rates of side effects of these anti-amyloid therapies, which will affect differential dropout in future clinical trials. We don't have a definitive recommendation of how to address this problem, but it is something that requires considerable forethought going forward in planning clinical trials. We may have to monitor dropout for the anti-amyloid therapies as concomitant medications, which is something we've not previously done before for any other concomitant therapies. We also may need to look at longer periods of time before an individual on these therapies enters a clinical trial. Currently, most have a cutoff of 6 months of stable therapy, but we may need to lengthen this out for individuals taking anti-amyloid therapies. We also may need to look at criteria for individuals taking these therapies that they can temporarily interrupt their treatment with their antibody, but still remain in a clinical trial for a novel agent. Hopefully this will be done in a standardized way rather than ad hoc for each individual trial that's being conducted. There are also some analytic methods that can be done, such as stratified randomization and adaptive trial designs, but these need to be considered because they do use much larger sample sizes than traditional clinical trials. And with that, I'll thank my collaborators in my funding and turn it over to the next speaker.
Thank you, Richard. So it's my pleasure to introduce Jordi Pegueroles from São Paulo in Barcelona, and his talk is entitled Tau Deposition Increases Along the Alzheimer's Disease Continuum in Down Syndrome in the Presence of Amyloid. Thank you, Jordi.
Thank you for the introduction. It's a pleasure to be here and present this PI 2620 data in this Down syndrome population. I have nothing to disclose. Just as a reminder, and as all of you know, DS is caused by the trisomy of chromosome 21. The triplication leads to an extra copy of the APP gene and causing the AD pathology that all of you know, beta amyloid plaques and neurofibrillary tau tangles. Evaluations of autopsy says that virtually all individuals with DS will have these two hallmarks at 35 years old. So these neuropathological findings are extremely similar in DS-related AD and AD and sporadic AD. On the other hand, we know that biomarkers are crucial in following the disease progression in AD. It is known that not only the neuropathological, but also the temporality of the biomarkers are highly similar between DS AD and AD-AD. In here, we can see that all the different biomarkers of the ATN and also the clinical follow the same pattern in both diseases. However, neither the temporality or the spatial pattern has been assessed in tau using the tau PET. Although in this conference we've seen some studies with some great talks assessing this topic. But the pattern of tau PET tracers in AD-AD is widely studied. In this study by Gordon and colleagues, they show an AD pattern with using the first generation tau PET tracer, and Zamit and colleagues also published another paper using Down syndrome data with amyloid negative and amyloid positive, showing that amyloid positive subjects has a higher uptake pattern of this tau PET tracer. But how the second generation tau tracers behave in Down syndrome is not assessed yet. So the main objective of this study is to study the tau burden in adults with DS using the second generation tau PET tracer, the PI2620, and specifically we will assess the tau pattern in this population, evaluate its relationship with the clinical status, and finally assess its association with amyloid PET. For this objective, we took advantage of the DS recruited in the Down Alzheimer Barcelona Neuroimaging Initiative, the DABNI cohort. This cohort is integrated within a health plan for adults with Down syndrome in our hospital. They has an annual assessment with clinical and neuropsychological assessment, and then hundreds of them are further characterized with biomarkers, CSF, plasma, multimodal MRI, and multimodal PET. From this data, 30 adults with Down syndrome had T1 MRI, the PI2620 tau PET, and most of them had also flutemetamol data. We also took 18 euploid controls for further analysis. Regarding the PET quantification, the tau PET quantification, we use the following pipeline. Basically, we segment the T1 using FreeSurfer, then the PET was co-registered to the T1 for better anatomical information, and scaled this PET by the inferior cerebral cortex segmented in the T1 MRI. Then we used the FreeSurfer toolbox for the PET surf, and we corrected the partial volume and projected the SUVR values into the surface. But the analyses were not only performed in surface, but we also quantified the tau PET in the 3 different Bragg regions, the Bragg region 1, 2, 3, 4, and 5, 6. So we did 2 different analyses with this tau PET data. Additionally, with the available flutemetamol data, we extracted the centiloid as described by Klang and colleagues in 2015. So these are the demographics of the sample that is split by diagnosis. And as we can see, we have a bigger proportion of females in the DS group, respect the control group that was highly balanced. We can see also that the age increases along the AD continuum in Down syndrome patients, and also that the amyloid uptake is also higher during the AD continuum. For the first goal, that was to assess the spatial pattern, the spatial tau pattern in DS. We used the symptomatic subjects, both prodromal and demented subjects, the maps of the tau, and we extracted the mean. And as you can see here, the pattern looks very much like the pattern in AD-AD, showing AD-like regions such as the precuneus or the temporal ROI. The second goal was to see the differences between tau PET and the clinical status of the adults with DS. And we conducted 2 analyses here. On the left, you can see the comparison vertex-wise using asymptomatic DS versus the symptomatic DS. And as you can see, the whole cortex almost and mostly the AD-like regions are significant in this comparison. And on the right, you can see also the distribution of the subjects in this two-box plot, the asymptomatic versus the symptomatic DS, and tau PET achieved area under the curve of 0.92 to split these two groups. We then assess the tau PET QVR in the three ROIs, so the BRAC1, 2, 3, 4, and 5, 6. And in all three cases, we can see that the demented group was significantly different from the asymptomatic DS group and the control group. Although there was a trend in the prodromal, we cannot see differences. Importantly here, I want to point out that both asymptomatic groups, both ADS and control group, has a QVR around 1. That means that the target value, the target ROI and the reference ROI had more or less the same amount of tau, meaning that there was no tau in those regions. Finally, for the third goal of this study, we evaluated the relationship between global amyloid as measured by centiloids with the tau PET vertex-wise. Here we can see that the PI2620 is related in the whole cortex with the amyloid load, but especially in those AD-like regions that are the ones that are in yellow in the figure. To further analyze the association between tau PET and amyloid PET, we assessed a relationship in the BRAC regions 1, 2, and 3, 4 in here. And here is the relationship between tau PET and amyloid PET in the BRAC1, 2, and as you can see, there is a quite good correlation. And when we split this sample in amyloid positive and amyloid negative, it follows the same pattern with the subpopulation. So there is a positive relationship in the amyloid negative subjects and a positive relationship in amyloid positive subjects. So amyloid is linearly related with tau in early BRAC stages. When we assess this correlation in the BRAC stage 3 and 4, we can see that there is also a good correlation pulling all the subjects together. But when we split the sample in the amyloid negative and amyloid positive subjects, we can see that there is no relationship in the amyloid negative subgroup, and there is an amyloid and tau relationship in the amyloid positive subgroup. So tau in late stages is only related to amyloid, only in amyloid positive subjects. So just to finish and wrap up these results, we've seen that the PI2620 tau PET presented high affinity in symptomatic DS, showing a similar deposition in Down syndrome as in AD-AD. Second, that tau PET deposition increased along the AD continuum across BRAC stages. And finally, that tau burden was associated with higher amyloid burden as measured by amyloid PET, sorry. And finally, I want to thank all my colleagues and especially the LMI for providing the tau PET tracer, and of course, all of the audience that is here today. Thank you.
Thank you, Jordi. Next, I would like to invite Juan Fortier, who's going to be talking about blood-based biomarkers for clinical trials of Alzheimer's disease in Down syndrome.
So thank you for the opportunity to present. I'll provide an overview of the work that we've been doing in the last few years with blood-based biomarkers and more in general a bit on also on fluid biomarkers. These are my disclosures. So we've heard in the previous talk that DSAD is a form of genetic AD. And due to improved healthcare in the last century, now people with Down syndrome live much longer and healthier lives, and now the average life expectancy in this population in developed countries is around 60 years of age. And contrary to what many people think, this is not a diminishing population, this is a growing population, mainly due to the increase in older folks, as you can see here in this data from the US. And with this increased life expectancy, it has become very, very evident that AD is the main disease, the main cause of death in this population, and that the penetrance of this disease is almost universal, as you can see when you follow individuals long enough in this longitudinal study with over 15 years of follow-up. And this is mainly driven by the duplication of the triplication of the APP gene in chromosome 21 that is both necessary and sufficient to cause early AD in this population, as recognized for the first time in the International Working Group criteria in 2014, and now also recognized by the NIA Alzheimer's Association criteria, and defining Down syndrome as a stage 0 at the same level as autosomal dominant AD. The aspect that I would like to emphasize is the predictability of the disease onset. Here we perform a meta-analysis, and we showed that the mean age at dementia onset in this population was around 44 years of age. And importantly, that the variability of disease onset in Down syndrome AD is the same as autosomal dominant AD. We can predict disease onset with the same certainty in Down syndrome as we can predict it in autosomal dominant AD. We know from the 80s that pathology is highly similar between DSAD and the different form sporadic AD and autosomal dominant AD. But what I would like to emphasize here is that Down syndrome is the only population in which we can study the natural history of AD pathology, because people with autosomal dominant AD do not die before. We do not have the brains to study the natural history of pathology. But unfortunately, some people with Down syndrome die before they develop Alzheimer's disease, and we can study the pathology. And so this offers unique opportunities for disease staging with biomarkers, and we can unequivocally say that a negative amyloid scan, for instance, does not equate absence of amyloid. A 32-year-old individual with Down syndrome will have amyloid in the brain with no doubt from pathological studies, and will have a negative amyloid scan. So this offers a unique window in the development of biomarkers and understanding the behavior. So how are biomarker changes? So if we have a similar pathology and biomarkers, what should measure is pathology, it shouldn't come as no surprise that the biomarker changes, the signature, should be similar in both populations. And so, for instance, in this study that we performed back a few years ago, we showed that the CSF signature of AD is the same, with the decreases of 50% in A-beta levels and a twofold increases in phospho-tau. So similar pathology translates in similar biomarker changes. But we saw that these CSF biomarkers had excellent diagnostic performance. But I think this paper was especially important also because it was the first to show that a blood biomarkers, in this case NFL, had also an excellent diagnostic performance. And I have to say that a clinical diagnosis of AD might be a bit more complicated in this population due to the pre-existing intellectual disability. So this is kind of a game changer as in the general population. Blood biomarkers can provide a lot of help for the diagnosis of patients with Down syndrome. But blood NFL, and in a follow-up study led by Dr. Maria Carmona, we showed that not only it was good for diagnosis, but it also had excellent prognostic ability. So even in those that remained asymptomatic, the levels of NFL clearly predicted who would develop a symptomatic AD in the follow-up, as you can see in this Kaplan-Meier plot. And I want to emphasize that NFL is a non-specific biomarkers in the general population, but in the context of use of Down syndrome, it is specific. And here we could see it in a follow-up study that we studied both NFL and phospho-tau levels in collaboration with the University of Gothenburg. And you can see that how the parallel changes in both phospho-tau, in this case it was the phospho-tau 181, and NFL changes. Neurodegeneration in this population is almost synonymous of AD. This is a more recent paper, and we studied also in collaboration with the CIDIS group in the GFAP levels. As in the general population, plasma GFAP is much better biomarker than than the CSF GFAP levels. But I would like to call your attention to the lower panel for several aspects. First of all, I would like you to emphasize the overlap between the red and the yellow curves, and those are individuals with autosomal dominant AD and GFAP and Down syndrome AD. You can see that the biomarker changes with age were exactly overlapping. I would also call your attention that we found very early changes in their 20s and late 20s and 30s before amyloid positivity via PET, but concomitant to the decrease in CSF that antedates amyloid positivity, we can still detect these elevations in GFAP, but with a big dynamic range that continue to increase well into their 50s and 60s and even in symptomatic stages of the disease. And that translated in a very good diagnostic performance too. So it's really big dynamic range. Very quickly, we've also analyzed some synaptic biomarkers. So this was in collaboration with the University of Johns Hopkins, and we analyzed also the pentraxin-2, and this was a very interesting biomarkers with decreases in AD to the similar level than in the general population. This is another biomarker that has been developed by the sterling work of Olivia Belbin. BAMP2 is a synaptic biomarker that correlates with cognition, and I think that once we modify the core AD pathologies, we will need other biomarkers to monitor the change in cognitions, and this, for instance, is a promising biomarker. So finally, I would like to emphasize the similarities in the chromopathology, the opportunity that DSAD provides, because as it has been emphasized by the previous speakers, the biomarker changes both in ATN biomarkers are extremely overlapping between DSAD and AD, but we have orders of magnitude more patients in Down syndrome. And so with this, we can really map out with biomarkers, with blood biomarkers, but with other biomarkers, we can stage the disease process. And this is something that we also want to emphasize. It's probably the only population in which you can truly choose when in the disease process to intervene in trials, or if you want to develop any biomarker. So with that, I'll conclude saying that, stressing that DSAD is a genetic form of AD with near full penetrance, that AD pathology and biomarker changes are similar to those found and described in sporadic AD and autosomal dominant AD, that the predictable sequence of clinical and biomarker changes in DSAD make it an ideal population for trials and also for biomarker development, and that, and this is my personal statement, that AD might be easier to cure in this population than in the general population. Is a much more homogeneous process, and that not to perform research is a form of discrimination and a huge missed opportunity. And with that, I'd like to thank all the participants, all our team in Barcelona, and specifically also all the team in the University of Gothenburg, which we have a really productive collaboration. And thank you very much.
Thank you, Juan. So we have a few microphones around the room, and we have a few questions online, and I also invite our panel to also ask questions if they feel they would like to. Is there any questions on the floor? Yes, Jeff.
Yeah, Jeff Daig, Indiana University School of Medicine. I had a question for Scott about the ventricular volume, and if you looked at plasma GFAP to see if it would be associated with those increases.
I think that's a fascinating question. It should be looked at. All I can say is that when There's an MMAB phase 2 study when NFL was related to volumetric changes. There was an association observed, but this is one of the analyses where we're calling to be done.
Question, Ilford Container Mayo Clinic, question to the same speaker. Have you done a mediation analysis to determine whether it's ARIA that mediates the brain volume changes in anti-amyloid therapeutic agent receivers?
We were not able to stratify according to people who had ARIA and who didn't have ARIA to do this analysis, but we think that this is something that we should do, the priority analysis we should do.
Hello, Marie-Claude Petit from the Paris Brain Institute. I have a question for the Sanpao group. I had the impression when you look at the amyloid negative Down syndrome, you see tau PET positive. Is that correct?
No, we see a positive correlation.
Oh, positive correlation.
Yeah.
Okay.
No, we then assessed an agreement analysis, and we saw that all tau PET positive were amyloid positive also, but
okay.
we didn't have enough time to show it.
Yes, okay, thanks.
Bengt Lindblad, I have a question to Mia Kivipelto. First of all, congratulations to the worldwide spread of finger. It's fantastic. But regarding your future study with combination with metformin, the non-pharmacological and the pharmacological, my experience is you have rather many gastrointestinal side effects of metformin. Do you see some possibility to predict which patients will have side effects to avoid dropouts?
Yeah, it's a very good question. Thank you, Bengt. First, we are using the slow release form, so that should minimize the side effects. And we are also having a very slow titration up, starting with 500, then 1,000, and up to 2,000. If the person can't tolerate the higher dose, they can go to the slower dose. So we don't exclude them, so we try to optimize the dose. But yes, indeed, that is one of the few, I would say, side effects or risk what we are having there. But we try to find the ideal dose. The second thing was why we wanted to test different doses. We did not know what's the best dose for brain health. We don't know if it's 1,000, if it's 2,000, so what is really the best one. So that's why it's a two-phase of the study, so that's the reason.
Just to follow up there, there's a question specifically for you here, Mia, so let's take this. Was the effect on the CDR sum of boxes significant in the finger trial? And what about AD risk reduction?
Yes, and you think the MIND-AD trial, right, where we had to see, yes. So in the MIND-AD trial, it was a feasibility study, so cognition was only an exploratory outcome. The feasibility and adherence was the primary, and then the other outcomes. CDR sum of boxes was significant after 6 months, and that was comparing the combination group and the control group. This is so far, and the analyses are still ongoing, but this is what we have found so far. Right. And the same thing for the healthy diet and the healthy lifestyle index and burden of vascular. So it seems that this group was able to have the healthier lifestyle, and it was reflected also in the CDR samples.
Thank you. Thank you.
Hi, Andrew Stevens from Life. I have a question for Juan. Thanks for the wonderful talk. The question I have is about vascular disease and in Down syndrome. And is vascular disease, does it come up earlier too? Does it have as similar as from a sporadic course, or is the Down's cases a purer and less confused system with respect to vascular disease?
Can you repeat the question? Sorry. Okay, mine wasn't working, sorry. No, that's an excellent question. So, first of all, there was a symposium on Wednesday, I think. It was specifically addressing this question. It is a fantastic question, because actually I think that we can learn from this population is that they have very little cardiovascular disease, and they have hypotension. But we find a lot of changes that are traditionally associated with vascular. And I believe this population is what is telling us, or my understanding of the pathology, is that there are a lot of vascular changes that are AD related. So that sometimes and it goes the same for synuclein. I think that pathologists put in different boxes the different pathologies we find, and we are always talking about comorbidities as if they were independent stochastic factors, and we are not taking into consideration the possibility that AD is driving some of these findings. And I think that a lot of the vascular findings that we have at pathology and MRI are primarily driven by AD, and in these genetic populations, there's no question. There is a lot of vascular changes, white matter hyperintensities, a lot of vascular changes that are found, and the same goes for alpha-synuclein. There is a very early alpha-synuclein deposition in Down syndrome, autosomal dominant AD, and I think that this calls for a reconsideration of our interpretation of pathology as independent factors from each other.
Yes.
A question for Dr. Kennedy. In your analysis of the kind of the novel clinical trials in which the amyloid antibodies are kind of standard of care, do you think that the class of medications for the class of targets for the no drugs might affect the kind of analysis that you do? For instance, if you had an amyloid target on top of amyloid antibodies, like a BACE inhibitor, would that be different than something like a symptomatic treatment or so? Do you have any idea about that?
It's a very good question that we don't have a definitive answer to right now. As far as different therapies, we did use rates of dropouts that seem to be similar for the newer agents, as well as for aducanumab. But if there is an agent that is targeting amyloid on top of the anti-amyloid antibody, if that does have a contribution to differential dropout, then you'll actually see even greater loss of power than what we demonstrated here than just with an anti-amyloid antibody. The amount of loss of power is going to depend on how much differential dropout you get with your new treatment as well as with the anti-amyloid antibody. Again, I wouldn't read too much into the simulations. I wouldn't say this is the exact amount of dropout or loss of power that we will get once these agents become widely used, but there's certainly enough signal there to raise concerns about use of these agents in future clinical trials.
Okay, thanks.
Yes, I have just a comment for the Down syndrome. I think it was very interesting to hear all the results, and just a comment that said some colleagues, maybe you are part of the Down syndrome consortia, proposed that we should have a finger trial for the Down syndrome population, given that there are indeed some lifestyle vascular metabolic risk factors, and it has been never tested. So maybe you are part of the consortia, but that proposal is out there.
Yeah,
we
actually are, and I cannot agree more with that. I think that's there is a lot of that we can learn in this population. There is very stress, there's a lot of comorbidities. It would be fantastic to perform such a trial. Thank you.
There's a lot of questions coming through, so I'll just take this one while we have one. This question is, which blood biomarkers do you think should be included for clinical trials with DS? And do you think we'll see the same effect of NFL increases in anti-amyloid trials in this population as you do with sporadic Alzheimer's disease?
So I think that we should use the same biomarkers. I mean, the more we learn about the biomarker changes, is the more the similarities between DSAD, ADAD, and sporadic AD are striking. So I think that we should follow everything that we've learned in our population to Down syndrome. I think Down syndrome offers a unique opportunities to study other things. So I think it's a two-way street. And with respect to the NFL, I think that is that's a surprising result.